with the absolutely great presentation of Professor Nekufar. I really enjoy it. Professor Nekufar, most welcome. Thank you for taking time to joining us again.
Hello, how are you?
Hello, most welcome. Thank you for
joining us. Good to see you, Dr.
again.
Thank you very much for all of your effort for this course, which I personally really enjoyed from each part of that, to be honest with you. And I think we are almost going to the end of the course somehow. Yes, am I right?
Yes, that's right. It is the last session. I had a brief explanation about this session, but at that moment, many of our participants did not present. Do you let me to have a very short introduction of this session that you start?
Of course, please go ahead.
I'm sorry. As all guys,
do you want me to unshare the screen for you?
No, not at all. No, not at all. If you enjoy a very beautiful butterfly there, that's in a balance with the two small stones. It's very delicate picture. I enjoy it. Thank you. I appreciate it. Hello again to all guys. Because some of our friends were not. They did not present at the time that I had a short introduction. I would have a short introduction again about this session. I would like to welcome you all to this last session of this virtual program. A big thank you all for following our all sessions. I'm sure you had an absolutely big growing knowledge about the evidence-based approach, and you will follow all the guidelines and the information that our fabulous presenter had during these 6 sessions in order to apply it in your life, in your research, in your practice, and I hope you do it. But definitely we know that we need to practice on it, do not forget it, and we need to review all this information we got in order to not forget it and review it and apply it in our life, in our practice and research. And the previous session, if you remember, it was an overview of the critical appraisal that was presented by 2 fabulous lecturers. If you remember, Professor Babu and Jakub. I really enjoyed it and never forget it. I want to listen to the lecture hundreds of times in order to hack it in my mind. Anyway, and today I lectures Professor Nekufar, Professor Shamshiri, and Professor Khami. And you have known all this respected lecture during the workshop. I don't want to introduce them again. You have known all this respected lecture. And Professor Nekufar would have a talk about the hierarchy of evidence, but which is very important, and interpretation of evidence that will be presented by Professor Shamshiri. The workshop will be finished with a short question and answer, and at the end, will be finished with a sum up of the entire purpose of this workshop. Okay, Professor Nekufar, the stage is yours, please. We are waiting. The stage is yours. We cannot hear you. You're on mute. Okay.
Thank you very much. Hello, everybody. And I don't know, I should say good morning or good afternoon or good evening, because we are very happy to have participants from around the world. I'm actually in my office, in my surgery. So therefore, I'm ready to go back to the clinic after I finish the session, which is the reason that we are here and the reason that we discuss about the clinic. Why we are here? Because we want to balance between our knowledge and give the service to our patient. This is our duty, and this is the most important goal of this type of gathering. We want to give a good service, a good care to our patient. And the reason that we discuss about the evidence, about the balance between the technical quality of a clinician and background knowledge of all the publication, including the evidence-based publication and laboratory-based publication and everything, is because we aimed to give good service to our patient. I'm sure you agree with me about that. One of the things that I'm very keen to have, and I think if I want to criticize our course, is the lack of interactive communication between the participants and whoever is going to give a lecture. I was actually in the lecture with Professor Venkatesh Babu. He is one of the world authority in this field. And he asked a lot of questions, and the only person who answered was Dr. Mutavassilian. I think she is going to be a very, very famous evidence-based dentist very soon, because she answered all the questions. And today, I'm very keen, if possible, to ask you again, please turn on your videos and stay with us, because then we can see each other in a very good way. And then I feel, as a person who is teaching for half an hour or 45 minutes, to have some of my students around me. Actually, now we are 4 of us. We are all panelists of today. So we are all of our videos open to you, but we need actually to see nice faces and familiar faces from our students to give back good energy, a good positive energy to us, to speak in a very interactive way. And the reason that we choose actually Zoom platform is this. Maybe we can run a clinical trial by the lead of Professor Khami and Professor Shamshiri about the effect of a good infrastructure of participant engagement in this type of communication. Because the thing is, I don't know actually my participants are already engaged or not. So this is the issue for this type of communication. I just finished around half an hour ago, I just finished another 1.5 hour lecture about ethics in endodontics. And in that one, the communication, even the quality of the connection wasn't very good like the one that we have now. This is very good comparing to that. But in that one, we had a lot of interactive discussion, which helps me to learn from my participants, from my friends, that they gather them under this umbrella of evidence-based. By the way, let's go and this slide was the last slide from my first session, from my first presentation, that I give you some information about how we can use the evidence in the clinical field, because this is the most important things that we need. When I have a patient, I should think about that. What is my background knowledge about that? What is the technique that I can use? And which technique is going to be more efficient? Which technique is going to do better performance with less chair time? Something like that. So I need the answer from the literature, and I don't know what type of literature I can trust. Then it comes to the hierarchy of evidence. Speaking about the hierarchy doesn't mean the hierarchy, for example, of royal family. We are not speaking about that. However, somehow this hierarchy indirectly gives us some sort of message from that type of hierarchy that we have in army, or we have in royal family, or something like that, that some people are workers, but some people are leaders on the top of this pyramid. I'm not speaking about is it fair or not? It's not my job to do that. But speaking about the hierarchy of evidence, that means when we want to decide, when we want to do something, we shouldn't use what we have at the base of this pyramid. What we have at this base, which is green here, like background information or expert opinion, it is necessary. I will show you some very important things about that. It is definitely necessary, but it is not adequate. The problem is that it is necessary. It is mandatory to have enough background information, for example, about anatomy. Can we do something without any knowledge of anatomy and histology? Obviously not. Can we do any type of treatment in the field of medicine and dentistry without having the knowledge of, for example, without having the knowledge of immunology? I'm sure it is not possible. So speaking about that with a medical doctor also, it is same. Medical doctors cannot do anything without having enough knowledge and adequate knowledge from basic science. But obviously, they cannot rely just on the laboratory studies. They cannot rely just on the pharmaceutical studies that a chemist or a pharmacist give them some information. So we as dentists have similar situation because, for example, speaking about endodontics, which is my specialty, speaking about comparing one visit root canal treatment to multiple visits. Okay, can you help me and tell me, should I multiple visits or should I do one visit? So I want to decide. Today I have a patient. Right now, after 1 hour, I want to start my first patient. And the first patient, it needs a secondary treatment or as so-called retreatment. Okay, can I finish that in one visit or not? So that comes to the evidence. I may say that I have enough information and I have enough ability and enough expertise to do the root canal treatment in one visit. But if it is a secondary treatment, comparing to primary treatment, can I do that in one visit or not? So then I need to go to the literature and find out and extract the data from the literature. Inside the literature, I may find something, but then it goes to the type of studies. I think during this course so far, during this 5 or 6 weeks that we have with you, we already covered the different types of studies. But now what I want to emphasize on that is, okay, speaking about different types of study is not enough. It's now important to say that which one is more powerful, which one is going to give us some information that we can use them in clinical situation. We need to be very careful. Each of them may have disadvantages and advantages, and each of them can do different types of job. So let's go further and see what we can do about that. So I start by the base of this pyramid, which is clinical expertise. Me as a clinician, and most of you as a clinician, may say that, okay, what we have done during 6 or 7 or 5 years of our study in dental school, and even after, if some of us becomes a specialist, what we have done during that 7 to 10 years, just clinical treatment, and increase our clinical expertise and clinical experiments. Sometimes we did something wrong, so we learn from our mistake as well. But we need to do such a thing systematically to give information from clinical expertise to make it as to do that competently without any problem. But what is the way to do that? Then it comes to the hierarchy of the evidence. Okay, can we do something without clinical expertise? Obviously not. What I said here, which is a very important message to us, is neither individual clinical expertise nor the best available external evidence works very well alone. So somebody from outside of our field cannot come to our field, read all this evidence and start doing something. No, it's not possible. It's like driving. When we want to drive, we need to know how to drive. We need to know how this machine works, and we need to know all the rules and all the risk even. We need to know the risk of different, for example, roads when we go outside and blah, blah, blah. But can we start driving straightforward after reading all the books, all the evidence about driving? No, not at all. We need that clinical experience as well. So we need to sit and do preclinical studies and post-clinical studies and a lot of things. We need to do follow-up. We need to do the job inside the clinical situation. A doctor without the clinical experience is nothing. We need clinical experience. But this clinical experience, without sufficient and adequate evidence, also cannot work very well. Okay, Without the best external evidence, clinical practice easily becomes out of date. That is the problem. And treatment efforts will go beyond adequate. This adequate word is very, very important. And we need to be very, very careful about that. We need to keep ourselves up to date. I remember that from the first session that we had with Professor Mohammed Khami, who is also the manager of the whole course, and we should thank him as well. He said that there is an explosion of information and we cannot keep ourselves updated. But we need to keep ourselves updated by using maybe second-hand information from the people that they already did the job for us and put everything together and give us some evidence or put them in a critically appraised, mini-critically appraised publication and something like that. But without that, without this external evidence, when I'm saying external evidence, I'm speaking about the evidence rather than the one that we can get from the clinical situation. Without that, we cannot do anything. However, as I said, neither individual clinical expertise nor the best available external evidence works very well alone. So we need both of them. We need that butterfly on one side and all the sun on the other side to make this balance to work. I'm sure Dr. Mutawassilin is going to enjoy from this slide again. So let's go further. So if we want to do such a thing, we need laboratory. Yes, please, go ahead.
May I ask a question? I'm sorry to disrupt you. About the external evidence, do you mean the literature?
Yes.
Yes,
okay. It's not just the literature, because again, speaking about the literature, as you remember, we need also somehow to look at the literature, criticize them, evaluate them, put some of them outside our field, and say some of them is not good, for example, or are they good or not. We should filter the evidence as well. Yeah. But sometimes the authors do the job for us and they publish something that we call them second-hand evidence. And this second-hand, when I say external evidence, I mean they are not our clinical expertise. Yes. We are not going to get them from the clinical area. But in the clinical, when you put your burr on the surface of a tooth, you learn from that each time. It's like a pilot that if they put in the logbook that, for example, they had another hour of flying, they give them more experience and they rank them higher and higher and higher. This is the clinical experience that we need. But this is internal. But we need some external information as well. The external information comes from the literature, comes from the experiments that other researchers may do and report it, and sometimes they don't prepare it. Then it goes to that gray literature that Wenke addressed them as well. I cannot judge on type of literature at the moment, but I'm going to speak about the different types of a study to show that even different types of a study, they have different level of, they can give different level of information to us before we overgeneralize them and before we use them in the clinical situation. That's a very good question. Thank you very much. But anyway, back to that. So as you can see here, to balance this, first we need the laboratory-based studies. Without these laboratory-based studies, especially in dentistry, without that, we cannot do anything. We need that. We need to know how to deal with such things based on the information that we get from the manufacturers, we get from the studies that people in dental material science may do that for us. Obviously, we can call them in vitro studies. In all of this in vitro and sometimes ex vivo studies, they may do a lot of things that we put them on the knees of the level of this pyramid. We put them under the base of this pyramid. Even they cannot go on the top level, but we need them. Speaking about this hierarchy doesn't mean that we are not going to use some of them, or we are going, because some people may claim that we are going to put some of them inside the bin. They don't have enough value for us to use in the clinical situation. No, that's not true. each individual publication, they have their own value. I remember again from the course that somebody asked about, can we run a systematic review on laboratory studies? And the answer is yes, we can. But again, the level of this evidence is not very high. That is the only thing. We can use that evidence as well as we can use other evidence by putting our background knowledge in this pyramid, and because this guideline said that, because that systematic review said that, I did this job, and if it goes wrong, then animal studies, obviously not. These days we heard a lot about the start from the laboratory based, working on, for example, some cultures that comes from tissue, that comes from cells, that comes from bacteria and other things, and then okay, animal studies. Again, we are speaking at the base of this hierarchy, at the base of this pyramid. And then it goes to chemistry and making something in the laboratory, make some medicine, some technique, some material. And this is all technical. But again, without this technical and without using these techniques in the lab and in animal studies, we cannot go to the clinical level and to the clinical trial. Then it goes to the clinical level. Again, for the clinical level, there are different levels as well. Why? Because of the number of variables that we encounter. The number of variables and the type of variables that we have, we need to be very careful about the design of our study. One of the bias that we should be very careful about, that the design bias. So when you want to do something, first of all, you need to define your aim. You need to define your goal. And then according to definition of your goal, you need to decide which study is going to answer to your question. So first, you need an aim. Then you need a good question, which is sometimes very difficult to find a good question. Then you find a good question. Now it's time to go to the design of this. And then you are able to design a good study and use the proper study, put that in the hierarchy of evidence, use that and the level and the power of that study. Don't overgeneralize it and don't underestimate it. So we don't underestimate any type of these studies. We use all of them at the level that they are in. So one of the very important information that we need is the data of internal anatomy of teeth, of the data of anatomy, histology, immunology. I put this micro CT scan just to show that how the technique can help us. For example, again, in my specialty as endodontist, without having the knowledge about the internal anatomy, I'm not able to remove the source of the disease from the root canal system. So I need the information from the laboratory studies to look at the internal anatomy and the complex internal anatomy of the tooth to be able to get rid of the source of the disease. You know that. Are you sure that you need to get rid of the internal tissues and internal inflamed or infected tissues from the root canal system? Then it's time for me to think about it. And you can see now there is a big paradigm shift to vital pulp treatment, because many people accused us of resectional treatment rather than regenerational treatment. So looking at that, this becomes a type of combination of the background knowledge and the clinical expertise and the clinical evidence. So when it comes to the clinical evidence, we need to compare different techniques with each other that we are going to discuss about that. But first, we need this information, then we use information to go further and further. What is this? Can you recognize this note? Do you want one of them or huge number of them or not? Dr. Motawassilian, are you going to pay us at the end of this course? Something like that?
I'm sorry, I cannot give my paid.
It is free for us even. Oh my God. So this is the queen. And this is a pound or a 20-pound note. I want you to concentrate on the necklace of the queen. What's the point? What is the relation of that to the clinic? And what is the relation of that to the evidence? Let's have a look. What am I doing? I'm going closer to the necklace. Can you see something in the necklace? Can you see something here? Yes or no? Can you see, Dr. Shamshiri, can you see something? You have very expert eyes by looking at the money. Can you see something?
20 has been written.
Not yet? Okay, let's go further. I'm using my microscope. I'm using operative microscope in endodontics. So I'm going further and further and further to show you that on the necklace of the queen, there is number 20 alphabetically and Arabic as well. 20, 20, 20, 20 to make sure this is a genuine 20-pound note. So how could I find such a thing? Look at that. I just put my microscope and I go further and further. What am I trying to tell you is the importance of microscope as a technical background. Look at this guy. Do you know this guy? This is young Nakufa. I decide to go back to the laboratory work and train myself for the use of microscope to be able to say that I am now competent enough to go inside the root canal system. Without this microscope, you are not able to find the second mesiobuccal easily. You are not able to find 5 canals in the lower molar, and you are not able to repair the perforation and blah, 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 blah. If you tell me, okay, do you have any evidence for that? My answer is, I'm not sure. I try to find some interesting evidence about the effect of microscope on the outcome of root canal treatment, and I couldn't find anything. Without microscope, also an endodontist can do the job, yes. But which one is more accurate? Still, we don't have evidence. Let me ask you another question. You know the importance of rubber dam in endodontics, don't you? Importance of rubber dam is very, very obvious. Without rubber dam in endodontics, you cannot do anything. And you know that if one of my students in the department, endodontic department, try to do root canal treatment without rubber dam, we fire them. We send them outside. And we know rubber dam is very important. If Dr. Shamshiri asked me, do you have any evidence to show that the importance of rubber dam? What is the answer? No. I don't have any evidence to show you that rubber dam is very important because it is not ethical to run any study without rubber dam. And it can apply to any type of evidence that we cannot produce those evidence. So be very careful. Don't use evidence as a gun against the clinician. Clinician may do something without knowing or without having enough high-level evidence in the pyramid, in the hierarchy of evidence. So you may say that, okay, usually when we are speaking about the hierarchy evidence, we should just discuss what is the difference between the cohort and prospective or retrospective cohort or blah, blah, blah. You are more expert than me about that. But what am I trying to say? What am I trying to give the message to our participants is to be very careful, because we as academic may sell something to you that you are not able to distinguish between true or false. We cannot produce high level of evidence for all the questions that we have in the clinic. If we have a rare, for example, condition or rare disease, then we are not able to run, for example, a randomized clinical trial or a huge number of cohort, for example. So therefore, we need to, after we increase the level of our knowledge, we need to increase our skills as well by using different types of instrument, different types of technique, and try to improve our competency to do the job. These images actually before the pandemic, so I really miss this time that we did our job in this way. But nowadays we are under a lot of protection and our job is very difficult. But now you can see I'm doing a surgery by using the microscope and by using the micro technique. Do we have any evidence to show that if we want to prepare the retro cavity when we are running an apical resection, it's better to use ultrasonic tip or a burr? Do we have any evidence? No, there isn't any evidence because it's not able to produce any evidence. So this is my take-home message to you, to tell you, you need some special technique, some especially laboratory, some special animal studies, and all of them are valid, but you need to know their validity and you need to know their level of evidence in terms of hierarchy. Look at that. This is the third mesial canal. So can you find such a thing without microscope? Very difficult, very difficult. Second mesiobuccal of upper molar, very difficult. And I'm trying to show off myself as well. Therefore, you can refer your difficult cases to me. Don't worry about that. I can handle that. But if something like that happens, this is an accident of pushing sodium hypochlorite outside the root canal system. Why this happened? Because without clinical expertise, patient care will suffer. And today because we are speaking about the evidence-based dentistry, and we emphasize enough on evidence, somehow I want to speak against the evidence. Not against the evidence, but I want to speak in favor of clinical expertise as well as the evidence. None of them alone is enough. None of them alone is adequate. You cannot drive based on reading the book. You cannot swim based on just reading the swimming techniques. You cannot. And you can, yeah, you may say that, okay, the effect of temperature on the speed of swimming, and you compare two groups in different pools, one of them 20 centigrade, the other one's 30, and the group in the 20 centigrade definitely can swim faster. What's the point? Can I swim now? No, I need swimming expertise. So clinical expertise is that. Without clinical expertise, patient will suffer. And on the other hand, without evidence, you are not going to have enough clinical expertise. That is the important thing. And this is the balance. See, this is another harm, another suffer. Because the dentist who did this job, oh, look at Dr. Mutawassilian. You gobsmacked Dr. Mutawassilian. I can see that. Why? Because without clinical expertise, patient care will suffer. You may say that, is there any evidence to show that? Do we need to fill the root canal system without, before placement or insertion, a post inside the canal? I don't know. I tried actually to make an evidence for that, but I use animal studies, just animal studies, because I'm not able ethically to leave the canal empty and then insert a post inside it. Or is there any evidence to show that if I use larger post comparing to a smallest post, there is no evidence? Because we cannot make any clinical evidence. There are some huge number of laboratory studies that confirm the idea. We can do the systematic review on them as well, but we cannot overgeneralize them somehow too. Still, so far, I think I emphasize enough on the level of evidence and the importance of evidence and the importance of clinical expertise, obviously. But the first level of the evidence somehow now started, case report. After we finish the background knowledge by having enough basic and everything enough and adequate, then it goes one level up, case report. I did the job very well. So I showed you. So I show you this. I remember that. Okay, let's review the case report first. This is a simple method of clinical research and try to show other clinicians about the technique, how to drive, how to swim, difficult case. Usually, it shows unique aspect of a disease or outcome of a new technique or unusual features of a disease or of a technique, obviously, or outcome of a therapy, just one therapy. I did this, it works, that's it. So now it comes to very important clinical question. If you leave it alone, you think it's not working? We don't know. If we have caries, and the caries is very deep, if I show you that I remove everything from the root canal system and it works properly, patient didn't suffer from any pain, you may say that, oh, wait a minute, why you remove everything from the root canal system? You may put something as a lining, as a base, and repair the coronal part, and that may work as well. So this is the main disadvantage of a case report of a very, very good clinical job. Okay, you did a very good clinical job, but on the other hand, you should think and say that, okay, if I didn't touch that, maybe the body itself can repair also the situation. So this is one of the main disadvantages of case report. I showed you this very interesting case from Mahmoud Rabinejad. That was a necrotic canine that Mahmoud Rabinejad filled that by the first prototype of MTA, and this regeneration happened. And unfortunately, I, as a young dentist at that time, and I'm still young, by the way, as a young dentist at that time, I followed that and it didn't work. Then we find it out by one case as a case report, even such a case report published in a very good journal with a high impact journal. We shouldn't overgeneralize a technique based just one case because there is no control. And the most important control is nothing. We should do something and compare that with nothing. Then compares the outcome. If I show you that, if I don't do anything, and if I do something, and I compare these two to each other, and at the end I show you that the one that I did something works better than that, then it is good. But if I show you that I did something and it works, okay, what's the point? Is it clear? Okay, so let's go further. Let's ask our participants now to help us. Definitely, I'm not going to ask Dr. Mutawassilian to answer to this question. And definitely Dr. Khami is not also eligible to answer my question. So I'm going to select somebody. Let's ask Kazan Omer Abdur Rahman, or maybe Manije Mohammedian, any of you. I ask both of you, Manije and Kazan, to unmute and tell me what you can see in this. Okay, go ahead, please. Any of you, whoever wants to answer, can raise their hand. Otherwise, I'm going to turn on your microphone and ask you to speak. Dr. Ahila, please go ahead. Dr. Ahila, no answer. Mike Agbaid, if I pronounce your name correctly, please. No. Maybe the admin can, okay, somebody try to turn on the microphone. I think it wasn't successful somehow. It looks like that it's not working somehow. No? Okay, let's ask Dr. Mutawassilian to help.
Thank you. Thank you, Gabe, for the opportunity, Professor Nakufer.
What do you see, Dr. Mutawassilian, here?
The first thing that what grabbed my eyes was about the first molar on the right. Is it right?
Yes, the problem is here. The problem is that we can see a radiolucent area around the mesiobuccal root of the lower first molar of right side.
Yeah.
So what's your suggestion? Extraction, pulpotomy, root canal treatment, hemisection, implants, bone regeneration? Which one? Quick.
You are my professor. I'm ashamed that the respondent.
Don't say that. Okay, carry on. Others can help.
Definitely would not the extraction. I should test the vitality of the tooth to find the reason. And if I want to retain the tooth instead of tooth extraction, probably I will ask a very expert endodontist like you to do the endodontic treatment to prevent the further root absorption to keep the tooth.
On which evidence? On which evidence?
Just now, I have no evidence to present it to you.
But I say that you should do root canal treatment. Why you say that? Dr. Khami, help me. What should I do, Dr. Khami? You are an expert clinician. What should I do? Root canal treatment, extraction, bicuspidization? What should I do?
Okay, so I think this is somehow complicated, but...
Yeah, it is. So ask me some question about the history of this patient. See, when you are going to the evidence, you need to increase your knowledge, put them together, compare with the guidelines. First things that we need to do for this case, and Dr. Mutawassilian is always doing such things, and write a very long report about that to me, is sensibility test. And when I test that, the tooth was vital, was sensible. So therefore, I decide to do nothing. And I look at the history of the patient, and I find an impacted premolar was surgically removed, and that tooth was the origin of the resorption, and the tooth was sensible. So I decided to do nothing. And this happened.
Great. Thank you.
Okay.
I told you, my professor, I cannot say anything in front of you.
Okay. I trap you in a very important thing. I trapped you to show you that sometimes by doing nothing, you may end up with a very good result.
Yeah.
So imagine if I did root canal treatment for this case, what happened? Again, healing. And I may say that, oh, I'm a very efficient endodontist by doing the root canal treatment in a very difficult mesial canal. Or if I put some biomaterial inside the mesial canals and show you that, okay, see, this is the regeneration. Yes. So that comes to the control. So we need control. We need to compare some technique, some treatment with some nothing, with doing nothing, and show that this technique can work or not. In medicine, they called it placebo or placebo, by giving the patient sugar, for example, and compare it to antibiotic. Give them sugar in a same capsule that they put, for example, analgesic inside it. I did actually one study myself, and I compare the effect of various yes, that was not antibiotic. That study was about just painkillers, different types of painkillers. I give them different types of painkillers and compare that with sugar. But this type of different types, that includes piroxicam, diclofenac, naproxen, none of them worked for post-operative pain in endodontics. So for post-operative pain in endodontics, sugar was efficient as naproxen. So what should we do? Do nothing. Do nothing. Sometimes doing nothing is not going to give any harm to the patient. So this is the second message. So don't overgeneralize any case report. Then you may say that, okay, let's have a look to the case series. Because if I did 20 cases, then that may give you more information. Yes, series of cases are more common and may give you some more information, may provide better information. And if you make it larger of patient, particular disease or condition subjected to this treatment can be studied. But the main disadvantage, again, for case series is lack of control group. So I showed you that case to emphasize on the importance of doing nothing. And doing nothing means control group. I'm sure Dr. Shamshiri is very happy because that is the first time some clinician is speaking about doing nothing, comparing to do something. Because we always ask Professor Shamshiri to help us to compare doing something. But then Dr. Shamshiri always asks us, what is your control group? Without control group, this is rubbish. Rubbish is not a good word. It is not rubbish, but in reality it is. Without control group,
I'm sorry,
we just say something. Yes, please, go ahead.
Thank you. About the control group, I did do nothing. Sometimes it is not ethical. Is it ethical? For example, giving...
That's a good point. I already mentioned that about Robert Down. I already mentioned different aspects of this story. I'm trying to make this story very simple, but in reality, it is not very simple. And the reason that we need epidemiologists, we need people that they know how to design this type of a study for us is that. Otherwise, we can do it ourselves, but we are not able to do it ourselves. We're just able to do how to ask them to do it for us. Yeah. So we always ask our epidemiologists to help us to design these studies. But now I'm just emphasizing on the importance and the knowledge of that. So if you have the knowledge, then you go and ask Professor Shamshiri to help you to design the study for you. And you know that we don't have enough and adequate information to design the study ourselves because there are a lot of important things that we may overlook them and forget them. So it is important. So for case series, we can utilize them to develop a hypothesis, but we cannot test this hypothesis. I may say that, okay, if you have an open apex, you may use PRF, platelet-rich fibrin. Yes, that's good. It is just to develop my hypothesis. Then you can publish that hypothesis in journals that they are not asking you for control. They're just asking you for the technique, like dental hypothesis. If you want to publish in Journal of Dental Hypothesis, please feel free to send it to us. I'm one of the advisory board or something of that journal as well. So that is very good journal, just because when you think about something and you want to publish that before running the proper study, they are going to publish that for the next generation to run the clinical trial and compare your hypothesis with nothing and show that nothing equal to hypothesis or hypothesis is better than nothing. Then it comes to the significant difference to confidence interval and stuff like that, that help us to understand which way is better. So repair of perforation by MTA is very important. I show you some cases. Look at this case, a perforation that was filled by gutta percha. I removed the gutta percha, I put MTA, and this is the follow-up. Fantastic repair. This is just case series. Can we rely on this case series? You may tell me, okay, you put MTA there. Why MTA? Why nothing? Why something else? If you just clean the canal and leave it empty, that may work as well. There are many studies that show that at least in animal level. I did one study that I cleaned the canal and I filled just the coronal part without obturation, and it worked properly. In animal, it worked. Obviously, in human being, in clinical level, I'm not able to do that, as you said, because it is not ethical. But there are some case series and case reports that, for example, a person who forgets to ask for the obturation of the canal came back after 2 years with a very nice healing. Then it comes to some sort of thinking about regeneration, some sort of very brave or very heroic approach to some very difficult cases by doing nothing or by doing very, very minimally invasive treatment. But I cannot show you the success of case series because case series, they don't have control as well as case report. Then it goes to case control studies. I'm almost at the end of my talk because I want actually to finish just at 3 o'clock to give the stage to the next lecture. Okay, case control studies are a bit better. Why? Because we already have control in them. In case control studies, comparing to cohort studies, especially to prospective cohort studies, they are cheaper. So if we have a hypothesis, after we publish our case series, we may go to the case control studies. And in case control studies, it is easier to run comparing to clinical trials or prospective cohorts. We need shorter time for data collection and we can report them quicker. But the problem is, because of this shortage of the follow-up, sometimes we don't know what happened over time. And we need very long-term clinical trials or very long-term cohort studies. And the main disadvantage of case control studies is selection bias and recall bias, which we already have that in some of the clinical studies as well. And I'm sure bias is going to be covered in the advanced course, or we already covered some part of that, but we need to go deeper to the different types of bias. And I'm going to use this opportunity and ask Professor Khami, who is the manager of this course, and he is the man behind all of this preparation. And again, I'm going to thank him for that. I'm going to ask him to run also the advanced course for the people that they are very keen to run such studies in the future. And then I will be one of the students of the advanced course for you and Professor Shamshiri as well to learn more. Okay, so another problem of the case control studies is when we look at the hierarchy of evidence, they are again at low level. We cannot overgeneralize, and we cannot use the result of a case control studies easily in the clinical level.
It seems that Professor Nekuvar has lost his connection, so I think we should wait, or maybe we can try to call him.
Sorry, all friends and participants, for the interruption that's happened. The connection was interrupted. Professor Nekufar will join us again in a few seconds. Thank you for your patience. We cannot hear you, Professor Nekufar. Please unmute your microphone. Okay, we should share it. Okay. Okay. He unmuted again. Professor Nekufar?
Okay, yep, that's working now.
No,
Sorry, guys, my internet disconnected. Okay, I'm sure. Okay, let's make it quicker. Okay, prospective cohort studies comparing to other type of clinical studies somehow give us valuable information on the efficacy of clinical treatment protocols. And also, if you want to find out the causation relation, it can help us as well. In dentistry, we can use it a lot because we don't need to change anything. As a dentist, we can clinically work in our normal manner and we just record everything, put everything together, design a very good study, and then use different types of statistical technique, different multivariate regression, logistic regression, univariate regression, put them together, put this data together, and find out something that we can say, not just correlation, but the causation, which I already discussed in my first lecture. Okay, treatment protocols assigned to different clinics can furthermore be used for comparison purpose. So we can run, for example, a multi-center cohort, and it gives a lot of information, and we need to set up the technique with each other, and also we arrange a follow-up, and when we set the follow-up with each other, we can work on that and publish the data as a higher level of the evidence. Then it goes to the best study design, which is randomized controlled trial. In the randomized controlled trial, if we can run such a things, I mean, in terms of ethics, if we can run such a things, we have a true controlled experiment. It is the one that I already covered. So when I said that do nothing using placebo, using nothing, doing no technique compared to the technique, it gives you a lot of information. And one of the very, very important things in this type of a study is randomization, because then you can use just single variable. In this kind of a study, you can observe the effect of just one variable, compare that with the control group that you don't do nothing in that. And the important thing is you don't decide which one is going to receive the treatment, which one is going to receive nothing, and then you compare them with each other, which is the main powerful advantage of this randomized controlled trial. I think for randomized controlled trial, we need one separate day to discuss about the advantage, disadvantage, limitations, power, importance, technique, and everything. So again, it goes to the advanced course. But this is the powerful tools, as many of the biases that affect non-randomized trial can be eliminated. So in this one, you can eliminate the problems that you already have with others, because in this technique, you already have two groups. It is the example that I told you, comparison of the treatment in one visit comparing to two visits. So whoever comes to your clinic, you randomly send it to each of these two groups, and then you do the treatment, and you look at the result, healed or not healed, and then you compare the result with each other and statistically compare them and report them. So I'm going to my last slide now. Thank you very much to stay with me, and sorry for the interruption by the technical issue. This is what we already covered to this level, which was the RCT. And after RCT, the one that we already covered last week, it comes to the second-hand information, or comes to the information that the experts start to filterize them by critically appraised, publication that can be based on the critically appraised individual articles, and then critically appraised topics or mini critically appraised topics, and end up with systematic reviews and go higher to the umbrella review. Thank you very much indeed for staying with me, and I just finished at 3 o'clock. Thank you very much, all of you.
Professor Nekufar, as before, I highly enjoyed it. It was amazing. I'm so thankful to God that had the opportunity to hearing your speech again. Thank you for taking your time. Best wishes for you. And I hope we have the chance to have other workshop and having your speech again in this type of workshop. Best wishes for you. Professor Khami?
Yes, okay.
Thanks for the opportunity from all of you and Professor Khami.
Okay, thank you. First, I want to just say hello to everybody who is present now in this room. In our last session of our virtual evidence-based dentistry course. And I would like to thank Professor Nekufar, who was with us from the beginning, from the planning phase of this course, and also as a lecturer in some of our sessions, and we really enjoyed and we learned from him. Like always, I've been Professor Nekufar's student from more than 20, maybe 24 years ago. So I really enjoyed your lectures. And just I want to say something about you had a slide about placebo. You said something about placebo, and we have the placebo effects also. I can remind that we had a professor in University of Helsinki, Professor Heikki Tuti, and unfortunately he passed away some years ago. But one day he told us that, have you ever used a placebo effect in your clinical practice? And we all said that no, not at all. And he said that yes, you did. Have you ever said to your patients that this antibiotic is very good, this analgesic is a powerful analgesic, so this is a kind of placebo effect that you have used in your clinical practice? Okay, so just to say something about one of your slides. And then thank you very much. I know you are very busy. You're from your surgery now, and you have many patients waiting for you. And I do have something about what you said, and I would like to thank you for that regarding this clinical experience, and also something about shortage of evidence-based dentistry. Today, I will have something about that. So thank you for opening this discussion in your lecture. And we can say goodbye to you if you want to leave us to go to your patients.
Thank you very much indeed. Thanks a lot. And I hope we can carry on discussing such things, because we can learn, all of us, from each other. And to finish what you said that about the placebo effect, I definitely agree with you. One of the good things is I personally have some placebo effect on my patient, because I'm a very smart and very somehow even the color of my clothes can have some placebo effect on my patient. So this is a real example. Obviously, the patients that you don't have this placebo effect on them. I don't know. Do you have any placebo effect, Dr. Khami, or not? I don't know. That's just kidding. Okay. And make just this is the sense of humor of me that always working. You know that I admire you always, and I leave you with all the participants and say goodbye to all of you. Thank you very much indeed, and we will be in touch.
Thank you, Professor.
Thank you very much.
I appreciate it. Thank you. Bye-bye.
Thank you. Just I want to say something else regarding the evaluation form that we have prepared for this course. So we will share the links in the chat box, and I kindly request all the participants to fill in that form, because it will help us to know what has been the strengths and weaknesses of our course, and it will help us to design maybe better courses in the future. So just please fill in, and it doesn't have any effect on I mean the content. I mean the answers you will enter in the questionnaire will not affect the certificate that you will receive. Just fill it to receive your certificate. So without any effect, your answers just we will consider them anonymously. So just please fill in the form to let us know how our course has been, and it will help us a lot. So we will share the links, and you can it is in the Google Docs, and you can fill in the questionnaire. And in two parts of it, just because there is a Likert scale, a 5-point Likert scale for the answers. So in that two parts, you should just scroll to the right to see all the answers. And then, because if you are here with your phone, you may just see 3 of the 5-point scale. So you should go just to the right, scroll to the right to see all the answers and choose the option that you want. Okay, so thank you very much. Dr. Mutawassilian, please go ahead.
Thank you, Professor Khami, for the explanation you had. And now the time for lecture, Professor Shamshiri. It would be appreciated if Professor Shamshiri kindly present his lecture for the audience. Stage is yours, please. Professor
Hello, everybody. Thank you very much. I'm trying to share my screen. Just a moment, please. Okay. So can you see my screen?
Yes.
Good. So thank you for presentation of Dr. Nekufar. Accidentally, I want to emphasize on part the first part of his lecture, and I want to emphasize in my presentation on the role of experts or expertise in evidence-based dentistry. My topic is about interpretation of evidences. We are here in steps of evidence-based practice after forming answerable question, after searching for evidence and appraising the evidence. We are here to make decision, to make a clinical decision for our patient and to apply. And as Dr. Nekufar mentioned, we should check our practice and find gaps of effectiveness and, for example, failures, and we should revise our practice. Okay. In this session, I will try to show the level of strength of evidences, and for example, in a clinical guideline, when you look at the recommendation, you should know the strength of the recommendation and the role of evidence in clinical decision making. Unfortunately, for applying the evidences in the practice, it's not clearly mentioned in the evidence-based practice the documents. For example, as mentioned here, evidence-based medicine or dentistry does not offer any systematic approach to the interpretation of the knowledge sources. So I want again emphasize on the definition of evidence-based practice, which is integration of the best available research evidence with clinical expertise and patient values, these circles. And for example, the specific definition for evidence-based dentistry by ADA, an approach to oral health care that requires the judicious integration of systematic assessments of clinically relevant scientific evidence, obviously related to patients' oral and medical condition and history, with the dentist's clinical expertise and patient's treatment needs and preferences to get the best result for the patient. These definitions of evidence-based practice, although the emphasis is on best evidence, but the best evidence does not replace clinical skills and judgments and experience of the practitioner. So I want to emphasize again on the expertise in this step of evidence-based practice again. If the evidences is strong for your clinical question, the importance of the evidence on your final decision making is high. However, if the evidences are weak, so your decision is mostly based on your expertise and the patient's value. Look at level of evidence again. As Dr. Nekufar mentioned today, according to the Oxford Center of Evidence-Based Medicine, the best level of evidence is for systematic reviews and meta-analysis of randomized controlled trials as 1A, and individual randomized controlled trials as 1B. Then it's pertaining to cohort studies, next case control studies and cross-sectional studies, then case series, and the fifth level is for expert opinion when we have no other evidences available. However, it's not always applicable for all type of questions. As you know, we have different clinical questions related to therapy, related to diagnoses, etiology and causation, or for harms and side effects, and for prognosis. For two of these four types of questions, the best level of evidence is pertinent to randomized control trials and systematic reviews of randomized control trials. I mean for therapy and prevention, and for etiology and causation and side effects. For diagnostic questions, the best evidences is related to those studies with follow-up. So I mean cohort studies and systematic reviews of these type cohort studies. And also for prognosis, we can't perform randomized controlled trials. So the best evidences is related to Inception cohort studies. And again, systematic reviews and meta-analysis of Inception cohort studies are above single cohort study. And here, for those who do not know the Inception cohort studies means those studies that enter the patients from time of start of disease, from the time of diagnosis. So because when you get the patient from the middle of the disease, for example, the diagnosis done in previous year, and you find the patient in this year, it's not an inception cohort. You should follow the patient from the time of the start of disease or diagnosis. So according to the type of questions, we should find the best evidences. And as I mentioned again, for therapy and prevention and etiology and causation and harm, the best is systematic reviews of RCTs, and for diagnostic studies and prognostic studies, the best is cohort studies, because we have no randomized control trial for these type of questions. For first example, I want to see you evidence-based clinical practice guideline on antibiotic use for the urgent management of palpal and periapical related dental pain and intraoral swelling, a report from American Dental Association. Here is the first page, and you can see the different colors. I want to see you one by one. Here is grade certainty of evidence. A grade is a checklist with some criteria to evaluate clinical guidelines. So the grade here is the name of the checklist for validation of clinical guidelines. For certainty of the evidence, the high is pertinent to we are very confident that the true effect lies close to that of the estimate of the effect. So the recommendation for your PICO, if is highlighted by high certainty according to the grade, it means that the effect lies close to that of the estimate of the effect. The next one is moderate. We are moderately confident in the effect estimate. The true effect is likely to be close to the estimate of the effect. And if the recommendation is highlighted by low, it means that our confidence, it means other recommendation, their confidence is the effect estimate is limited. And for very low, it means we have very little confidence in the effect estimate. Next table. Okay. From the left, you can see the recommendations provided by the guideline is divided for application to the patients, to the clinicians, or to the policymakers. So there is not a single recommendation for different target population. We named them these type of population stakeholders, patients, clinicians, and policymakers. And the recommendations categorized as strong recommendations and conditional recommendations. For example, for patients, you can see the strong recommendations. Most individuals in this situation here, most individuals in this situation would want the recommended course of action, and only a small proportion would not. And a strong recommendation for clinicians means most individuals should receive the intervention. And for policymakers, strong recommendations means the recommendation can be adapted as policy in most situations. However, for conditional recommendations, here for patients, it means the majority of individuals in this situation would want the suggested course of action, but many would not. So it depends on the patient. The conditional recommendations for clinicians is the second row. It means recognize that different choices will be appropriate for individual patients and that you must help each patient arrive at a management decision consistent with his or her values and preferences. And for policymakers, conditional recommendation means it will require substantial debate and involvement of various stakeholders. So by these categories and these remarks, they try to guide the users of the clinical guideline to make the appropriate decision. And here is the recommendation, for example. So here, as you see at the top, expert panel recommendations and good practices statements. So here you see that the certainty of the evidence is very low because it's based on the expert opinion. And here, the expert panel suggests dentists do not prescribe oral systemic antibiotics as an adjunct to definitive conservative dental treatment for immunocompetent adults with symptomatic irreversible pulpitis with or without symptomatic apical periodontitis. As you see, the certainty is very low and the strength of recommendation is conditional. It means when you want to make a clinical decision for this question, you should decide mostly based on the patient's values and your expertise. For next question, the expert panel again recommends dentists do not prescribe oral systemic antibiotics as an adjunct to definitive conservative dental treatment for immunocompetent adults with pulp necrosis and symptomatic apical periodontitis or localized acute apical abscess. Again, the certainty is very low. However, the strength of recommendation is strong. It means that in most cases, it should be done. Another example, a non-surgical treatment of chronic periodontitis by scaling and root planning with or without adjuncts, a clinical practice guideline. Apart from the details, here you can see there are a different classification for saying that the strength of the recommendations is strong or in favor, means moderate or weak, or here based on expert opinion in favor of recommending the intervention or against the intervention and other classifications. For example, here is a question, scaling and root planning, no adjunct for patients with chronic periodontitis, clinicians should consider scaling and root planning as the initial treatment. Here, the strength is in favor. It's not strong, but it's moderately recommended. and so on for other PICOs. Okay. Applying the results of the evidence in clinical practice. Once the methods are determined to be valid in a step for critical appraisal, the fourth step is to determine if the results, potential benefits or harms are important or not. So here we should focus on the association between each intervention and the related outcome. The strength of the association, here I want to emphasize that the strength of association is related to clinical importance, not a statistical significance. We should at first define the clinically important difference between intervention and its comparison, and then should look at the p-value, for example. And at the last but not least, the condition of interest. It means the patient's problem, the circumstances and context, for example. Here, statistically, you can find the difference between intervention group and control group or comparison group in different ways. When the outcome is a continuous variable or quantitative variable, they provide, for example, mean differences, or they provide the change of the outcome in comparison to their baseline as a percentage. For example, a 50% increase or decrease of a continuous variable, and they report mean changes in percentage. Or if the outcome is a categorical variable or qualitative variable, they provide odds ratios, for example, to say the association between the intervention or risk factor with the side effects or disease, or risk differences, a different type of risk differences, risk reduction, absolute risk reduction. Sometimes they said attributable risk, and or they interpret the strength of association with some indices like number needed to treat, the number of patients you should treat with new intervention to get one benefit more than routine care. NNT means the number of patients you should treat with new intervention to get one benefit more than the routine care. Or other indices, for example, number needed to harm, and so on. Now, a question. Which intervention is better? Those interventions with high NNT or those interventions with low NNT? Dr. Motawassilian, I can't see the Zoom screen. Please.
Yes, I'm here.
Yeah, please tell me the feedbacks of participants. Thank you.
I should answer or the participant?
They should send one if they think the high NNT is better than low NNT, or send two if they think low NNT is better than high NNT.
I think high NNT is better.
Oh, so what's the feedback of the participants?
Yes, we have now 5 twos.
Okay, okay.
And no one.
Good, good, excellent. Because the number of, if you get more benefits with a smaller number of patients, so the intervention is highly effective. It's good. Thank you. Thank you for all participants. Good. So the right answer is low NNT. Thank you. Again, if you want to interpret the evidence based on a statistical, you should first focus on the strength of the association of intervention and outcomes, because the clinical importance is more valuable in your practice than statistical significance. So at first check for clinical importance and then check for the p-values. And with the statistical nomenclature, it refers to effect size. The effect size is somehow complicated from clinical importance, but it contains clinical importance, and also it emphasizes on the precision of the statistical inferences. I mean 95% confidence interval. So high association with low precision is not good. They resulted from those studies with low sample size. But if you get a high strength with a study with high sample size, so the precision is high and the effect size is very high, and you can rely on the both clinical importance and statistical significance. Now, beside of a statistical aspect for interpreting the evidence, here I want to focus on expertise and the role of expertise in interpretation of evidence, because there are some problems when you want to rely on the evidences. You have a good PICO question, you find some evidences related to your question, and you appraise them, and you find that those sources of information are performed perfectly, they reported carefully, and you can rely on their results. However, hypotheses are based on contextual knowledge. Trial designs is influenced by personal preferences, and interpretation of trials in their conclusions results depends on prior beliefs. So, for example, if you practice in Iran, the evidences from the Europe may be completely different from your contextual area. The researcher preferences and beliefs to conclude from their researches completely may be different from your country and your expertise and your patient values. So here you should rely more on those evidences that are closer to your contextual knowledge and your patient's values. Is somehow related to the philosophy of science. There are arguments between new interventions and routine practice, and there are two main approaches to decide which one is better, deductive approaches or inductive approaches, and all of them have sound and unsound decisions, or strong or weak decisions. So we should perform more practice. We should try harder to find the best evidence for decision making, relying on the recommendations of perfect guidelines. It may be not work for your patient, and this is a hard step here. Excuse me. Okay. So, expert opinion plays an important role in all essential steps of the pursuit of knowledge in the research tradition. Here, they want to say that expertise and expert opinion is a complementary rather than the hierarchy ranks. So it's better to pay more attention and to get more roles for expertise and your expert opinion when you want to decide which recommendation is more beneficial for your patient or which one not. My presentation is finished sooner than the schedule, and here is my references. If there is any question, I'm here to answer you.
Thank you, Professor Shamshiri, for your presentation, and very nice view you have at the end from the snow on the mountain. It's great.
It's your kindness. Thank you very much.
Your presentation, your great presentation, was ended with a very beautiful picture on a mountain with the snow cover all the surface. Thank you, I appreciate it. I enjoyed it. I need, if I were, I do not know, if I the other student and other participant, I review the slide that Professor Shamshiri presented to us, to review all this information, to use all of them practically in our practice and research, to know how we can evaluate and judge them, judge the evidence that we have, judge how to interpret the data that we had. We need to evaluate again and memorize them to practically use it. Professor Khami, do you have any recommendation?
Okay, so thank you, Dr. Shamshiri, for your presentation. So as the final step of evidence-based approach, you covered nicely the area of interpretation of the evidences. And now we have time for some questions. I think if there's any comment or question by the audience, we can now have the questions, and then just a small break. And then at the last presentation and conclusion of the whole course, I will have some slides to present. Okay, so if there's any question or comment by the audience, we can now have the comments and questions. I just again request all the participants to fill in the evaluation form. The link is in the chat box, so you can easily follow the link and complete the questionnaire. It has some different parts, and at the end of the question, at the end of the form, we have a place for your comments and suggestions. Please write down if you have any regarding the whole course or any specific topics in the course. So it will be the benefit of the future courses if you want to have.
Thank you, Professor Khami. Apparently, there is no question. Yes. Before starting the next part, is there any? No, there is no question. So do we have 10 or 15 minutes break?
Yes, I think 15 minutes is okay. And then
we'll continue. So in 15 minutes, we ask all the participants to come back and again join us to continue, and we have a presentation. We would have a presentation by Professor Khami and a short question and answer. Okay, I will come back, and you come back again in 15 minutes. Thank you.
Thank you.
Thank you.
Dr. Mutarasselian, we cannot hear you. I think you are muted.
Do you hear me now?
Yes, now we can hear you.
Thank you. Thank you. Just I know I arrived because the door was locked. I'm sorry for the delay. Again, thank you, participant. Come back and again join us. I hope you have had a short rest. And now we are ready to continue our workshop, the last session by presentation of Professor Khami. Professor Khami, the stage is yours. Would you please turn on your microphone and share your slide with us?
Yes, sure. Okay, so if I just can, okay, so. Okay, hello everybody, and again, thank you for being with us. We will share the link to the WhatsApp group that we have formed for all the participants to be a member in that group.
Yes,
soon again. Yes, we have shared it, but we will do it again, and I again ask the participants to join that group, because we will share our presentations, our 2 days presentations in that group also. And as the previous sessions, you can see the video of this session also in our website, in the link that you will have it. Okay, so now I start my presentation. Okay, so can you see my slides now? I hope you can see my slides. So I continue. Okay, just that in this short presentation, I just today I try to search something new about evidence-based dentistry, just to see if there is any new aspect or new articles. What are the new articles in this field are speaking about? So this presentation is just a few slides just to have a better and a deeper insight into the topic of evidence-based dentistry, as we covered all the aspects at this level that we are through our previous sessions, and today is our last session. So I tried to search evidence-based dentistry in MESH database, as we discussed how to search MESH database in Medline and PubMed website. And as you can see, this slide shows the evidence-based dentistry. Evidence-based dentistry is a MESH term by itself, and you can see its status in MESH hierarchy. So we have 2 approaches to evidence-based dentistry, from the category of disciplines and occupations category, and then health occupations, then dentistry, and then evidence-based dentistry. This is one way, and the other way is again health occupations, the same as what we had. But in the second approach, you can see evidence-based practice above evidence-based dentistry. And you can see here the definition of these 2 terms. We have the definition of evidence-based dentistry earlier. Also, Dr. Shamshiri had this definition in his presentation. And we have talked about these 3 aspects of evidence-based dentistry. But you can see here also the definition of evidence-based practice. Here there is, you can see maybe some differences, or because evidence-based practice, as we could see in the hierarchy in the MESH, is inclusive of evidence-based dentistry. So there might be some differences, and we expect that this evidence-based practice is more comprehensive than evidence-based dentistry, not only covering other disciplines, but also some other aspects, because you will see in my next slides what I mean by the difference between evidence-based practice and evidence-based dentistry. Dr. Nekufar said something about this and opened this discussion, so I try to continue and put more light on this difference. Then I searched with this evidence-based dentistry in the PubMed database. It resulted in 631 articles. It's not so a high number of articles because the whole topic is something new. You know that evidence-based medicine and after that evidence-based dentistry, they are somehow new concepts compared to the other concepts and topics that we are searching for. And then I try to just focus on the most recent articles, and I selected 3 articles to show some highlights of these 3 new articles to you in this presentation. And the first one is this article you can see here, How Evidence-Based is Dentistry Anyway? From Evidence-Based Dentistry to Evidence-Based Practice. It has been published in this year in British Dental Journal. So I just have put some highlights of the article here and in the next slide. So dentists have been slow on the uptake of evidence-based techniques. Surely because it is about evidence-based dentistry, it's talking about dentists, but I think this is also true in other disciplines, not just in dentistry. But this is in this article is regarding dentistry in British Dental Journal. And then the article discusses why this has happened, why dentists have been slow on the uptake of evidence-based techniques. And it tells that the evidence, the most, as we discussed several times in our course, that systematic reviews can provide the high-level evidence for us. But this article says that systematic reviews are only useful if they provide answers to clinical questions. And then it has an example that out of the 170 Cochrane systematic reviews on dentistry and oral health, the vast majority are unable to provide robust clinical recommendations. So they do have recommendations, but they are not robust clinical recommendations. This can be somehow shortcomings of systematic reviews when we are talking about clinical and daily clinical practice. Then it discusses about the main barriers to implementation of evidence-based dentistry into practice. There are many studies, as this article has called. There are many articles, and the main barriers can be categorized as insufficient time from the dentist part, from the clinician part, then inadequate training in evidence-based dentistry, and then the lack of relevance of the evidence to the practice. This is the point that this article wants to highlight, as the topic and the title of the article is From Evidence-Based Dentistry to Evidence-Based Practice. It has repeatedly been shown that when dentists are searching for help or advice, they would instead turn to colleagues. So it's much easier for a dentist to ask a colleague when he or she faces a problem. Sorry. Okay, should I continue?
Yes, sure. Sorry for any interruption.
Okay. So they are. It's much easier for them just to ask a colleague for their questions and problems in their clinical practice. So we need to be refocusing from evidence-based dentistry to evidence-based practice. And what does this mean? As this article says, this means that when we want to apply and implement evidences to our clinical practice, we also should consider our situation and other situations of a clinical practice, not just the evidence. Dr. Nekufar nicely explained about this. So some other aspects should be also taken into consideration. For example, something like cost effectiveness of a treatment. We know that, for example, the evidences say that, for example, this treatment is very good, but what about the cost? What about the techniques? Do we have the skills and the techniques and even the devices that we should use to apply the new method or the new procedure? So this evidence-based practice means that in addition to the evidences that we find in our evidence-based approach, we should also take into consideration the other aspects of our clinical practice. And then it continues that one of the weaknesses of evidence-based dentistry, as it is currently understood, is that it does not explicitly factor in real-world practicing issues, for example, cost and ease of implementation of techniques, as I told you. So these are practice-based factors that they should be considered in addition to the evidence. So this is the difference between evidence-based practice and evidence-based dentistry. And as Dr. Nekufara also told, not all clinical problems in dentistry can be answered by randomized controlled trials for reasons of ethics and feasibility. As Dr. Nekufara said, it's not possible to test all the techniques and all the procedures in randomized controlled trials. We do need less research, but of higher quality. And the other important things that this article emphasized was the qualitative research. So we should try to utilize the reliance on the trusted source and develop. This is another point. But regarding qualitative research, the article says that qualitative research can also be valuable as quantitative research. We traditionally like and prefer quantitative research, but qualitative research can provide and can put light on the aspects that they cannot covered by quantitative research. And when we do first a qualitative research, then after that we even are able to design and do a better quantitative research. That can be somehow a predisposition for a good quantitative research. So, and the article says that some of the aspects of dentistry can just be covered or only be covered by qualitative research, not by quantitative research. And the other point by this article is that we should try to utilize the reliance on the trusted source and develop easy to access, easy to follow evidence-based clinical practice guidelines. So we know the terms clinical practice guidelines. So this means that, as we had also in our previous presentations, the clinical practice guidelines and the website and the databases that they contains and include these clinical practice guidelines. These clinical practice guidelines and the websites and the databases that present this clinical practice guideline, they in fact trying to translate the evidences into practice. So a clinical practice guidelines is, we can say that it is translation of the scientific evidence to the clinical practice. And there is also, you can see here, because the article was published in British dental journals, so the example of these websites and guidelines are here, produced by SDCEP and FDGP in the UK. So these are some websites that provide clinical practice guidelines, and the difference with primary evidence is that they are easy to follow and easy to implement. And this is better for dentists because, as we saw, the dentists are in shortage of time and they cannot go through all the evidences. But when we have prepared, we can say that the second-hand evidence for them by integrating evidences, and we have prepared clinical practice guideline, then it is possible. It's more convenient for the dentist to follow these clinical practice guidelines. But the problem is that it's really difficult to develop a clinical practice guideline. It has many steps, and they should be followed accurately to in the final steps. Then we can have a good clinical practice guidelines. This was the first article.
Sorry to disrupt you. Do you hear me?
Yes, yes. Please.
I'm sorry. Dr. Paktaman has a question exactly related to just the slide you just recently presented.
Yeah. Yes.
Can I read it for you?
You
can read it by yourself, or I read it for you. The question of Dr.
I think yes. So please, I think you should read it. I cannot see it.
Yeah, Dr. Paktaman asked that is there is a lack of relevance, as you mentioned, between evidence and practice. How we can narrow the gap?
Okay, so exactly this article is talking about how to narrow this gap. So their solutions have been this qualitative research, these clinical practice guidelines, and these less research but of higher quality. These are the gaps, and the other solutions, as we can see in the previous slide, because if you focus on the barriers, then we can think about the solutions. So inadequate training in evidence-based dentistry is also a gap. So courses like this and the other courses are important for dentists and for dental students to be familiar with this approach. And in fact, with this way of thinking, critical thinking, not just accepting all the information that they receive. So this is also a gap, and the solution is to trying to train and practice evidence-based dentistry in our dental schools, and also as continuous education programs for graduated dentists. And regarding the lack of relevance of the evidence to the practice, as I told, there are some solutions and something in this article that I discussed. For example, those clinical practice guidelines and trying to integration of evidences for those who want to use them, that they are dentists. And refocusing from evidence-based dentistry to evidence-based practice. You can, I recommend Dr. Paktaman to read the whole article. It was a good article, and I can even maybe, yes, you can see here the article and the address. It contained, I think, good discussion points in it. So I recommend her to just study this article, because these are just highlights, not the whole article. Okay, and then the second article was, it was a systematic review published in a Journal of American Dental Association. And the title was Barriers Involved in the Application of Evidence-Based Dentistry Principles. And the authors synthesized and classified the barriers in 4 categories: self-related, evidence-related, context-related, and patient-related barriers. And we can now understand what does these terms mean. Self-related goes back to the dentist, for example, the lack of time and so on, because it has been estimated that if a dentist want to be up to date and know the latest evidences in the field of dentistry, he or she should study 1 article per day for the whole working, years. So this seems to be impossible. And the evidence-related, as it was said in the previous article, that evidence-based dentistry is somehow incomplete in the field of new techniques and materials. So this is somehow a barrier related to the evidence. So it is not so advanced. Evidence-based evidences are not so advanced and conclusive when we are talking about materials and techniques in dentistry. So this is also a barrier. And then the context related, as I told, sometimes we have good evidences for something, but we cannot apply in our practice because of the problems related to the context. For example, we know that implant is the best available treatment for edentulous areas in the mouth. But we know that it is an expensive treatment. So this is so you should forget about the evidence, and for example, you should put a complete denture or partial denture for the patient. So this is a barrier related to the context. And then the patient's related barrier, it is about sometimes the patients, they are reluctant to accept the new treatments or the new procedures. So everything is okay. You have the skill to do the new procedure. The patients even can cover the cost. You have the technique, you have the equipments that are needed to do this new procedure, but the patient refused to this treatment. So this can be considered as a barrier related to the patient. Then, as reported by this systematic review, shortage of time and financial constraints were the barriers most frequently studied. So in various studies regarding barriers of evidence-based dentistry, these two barriers have been reported most frequently. And then the authors, as their conclusions, the authors encourage practitioners to participate in educational programs focused on training in evidence-based dentistry abilities, in addition to seeking accessible and synthesized formats of reliable scientific knowledge. So this was also the conclusion of this article. And the third article was, it was just like a letter to the editor. And the title was, "Are We Making an Impact?" And it was published in Evidence-based Dentistry Journal in 2019. And the authors, Professor Elizabeth Kay from UK, she discusses in this article that the researchers keep doing what they do because they want to leave the world, in this case, the world of dentistry and oral health, a better place than when they came into it. And she says about the personal experience that in one of the big conferences, she asks the researchers and scientists that why you are doing what you are doing? What's the reason that you continue research? And according to the answers by the participants, she says that many of them, they just want to make the world better. So, and then she says that in order to have some way of measuring whether researchers are doing what they are supposed to be doing, their owners, their bosses, and employers need a metric to assess the quality of the research being produced. So the aim of the researchers is to have some impact. And how to measure this impact? In this article, Professor Kay discusses that we have a metric, for example, for the science, which is impact factor. But does impact factor really related to impact? Because impact means impact on the society. For example, solving some important problems for people, for individuals in the society, for their health, for their well-being. This is the true meaning of impact. But impact factor just talk about the citations to articles. So it's not related to the impact that the researchers, they really want to have impact on their society. And so it tells about the word impact and says that, okay, it seems that our metrics cannot measure what the researchers and scientists really want to do. Okay, so this was just to know what are the trends now regarding evidence-based dentistry. It seems that we do need education, training in this field. We do need to work on clinical practice guidelines. We do need to translate evidences into clinical practice. And all the audiences and participants in this course, they have this responsibility where they are in any country that they are, to put one step forward, to move one step forward this topic, evidence-based dentistry, in the context. And I think this is because all those who have participated in this course, they have shown their interest in this field. And now it's the time for them to do some practical things. And they should think about what they should do, what they can do regarding this evidence-based dentistry and evidence-based approach. So, and again, this is my contact information, and if you want, you can contact me if you have any question. I will be happy to answer. And so now, if there is any other question, I'm ready to answer. Thank you. Thank you for your patience and for your attention.
Thank you, Professor Khami.
You are welcome.
I really enjoyed it as your previous lectures. In briefly, you summarize all the required information that in which point all the participants, whether they are practitioners, whether they are researchers, should focus on in order to reach an evidence-based approach. So you just notes and summarize all the important points and factors. Thank you. I appreciate that.
You are welcome. I just want to ask.
All the topics in several slides. Thank you.
You are welcome. Thank you very much.
Thank you.
But I don't know if Dr. Shamshiri has anything to add to my presentations.
Sure. Yes, Professor Shamshiri, if you have any other notes to let the audience know, we will appreciate it.
Okay, thank you again. It's enjoyable for me to participate both as a participant and as a speaker. I want only add for evidence-based dentistry, don't think that the evidence-based dentistry is for a single practitioner. Think about that we can change our clinical practice in our clinics to the evidence-based clinics. I mean that for harmonizing the practice in a clinic, it's better to define the questions and find the appropriate answers based on the best evidence and by the decisions made by all practitioners in that clinic. And by revising and updating the answers to these questions, the clinic could always be evidence-based and be an update and up-to-date clinic. Think about the evidence-based clinics and evidence-based departments for students, because in education also the creation of good questions, especially for postgraduate students, is very important, and finding the answers and discussion with the professors are very important, and it's good for them after graduation and working in their office.
Yes, that's right. Thank you for the notes you mentioned to that. But according to the explanation of Professor Nekufar and also Professor Khami, and as Dr. Pakdaman has written here, it's highly important to educate a student to think critically. Do not accept everything. Do not read it and accept it and do it, but read everything and critically appraise it, that whether it's right or wrong. But in reality, in clinical practice, as like Professor Khami told us, we could not find evidence-answered-based approach for the treatment. And also, as Professor Nekufar explained, we cannot always follow the evidence-based dentistry or evidence-based documents to use it practically in dental practice. It's difficult to use it and from different points of view. And anyway, but this short course helped us to know how we should critically think about the document that released to us. Do not accept it. It was explained in different sessions from different prospects, and it was useful, and it will be useful for all the participants to use all this approach in their life, in their practice, and their research. And I hope they have joined this, and as I mentioned, improve their knowledge how to think critically about everything they heard, they listen, I do not know, even the news. They should critically think about the news they receive by different data, by different sources. Anyway, I would like to say on behalf of TUMS, I would like to thank all the participants for their valuable contribution and their interest in this program. And reach the end of this program, I would like, according that it is near the end of 2020, I should say Merry Christmas to all those Christians and also the Muslim. There is no difference. Merry Christmas and Happy New Year. To all of you, wish you safety and health in this COVID-19 condition, and health wherever you are, now and for always. And I hope to see you soon after ending COVID-19 pandemic in Tehran. As one of the postgraduate students, one of our program, many postgraduate program we have in dental faculty of Tehran University of Medical Science. We hope to see you soon in Tehran University of Medical Science. Professor Khami, if you have any speech for the end of this program, please.
Okay, thank you very much. There is a maybe question by Dr. Paktaman that the problem is dentists do not have time, and I think it's really difficult for them to be updated in each topic. Yes, I try to cover this topic. They need a ready-made solution, and the ready-made solution is the website and databases that try to translate the evidences into clinical practice, as I tried to cover. There are some of these databases, and we can use them. Yes, you're exactly right. And then, okay, it seems that there is no other. Yes, okay, there is no other comment, and just okay, at the end of this course, it's always difficult to say goodbye. But I just want to say that one of the byproducts of this course can be a network from all the participants of this course throughout the world. We can maintain this network. And I just was thinking about doing some, multi-center research to know what is the status of evidence-based dentistry in the dental schools around the world. There are some studies regarding this, but in individual countries. But maybe we can have some multi-center research with the same questionnaire, but in various clinical settings or various dental schools around the world. We can do it. So we can maintain this network. That WhatsApp group is one way, and then okay, that was one point. And the other point, I want to really thank Dr. Fariba Motawasselian. Without her enthusiasm, be sure that this course would not be held. She was very keen to do this course, and from the idea and pushing me forward to do this. I would like to really thank her, and her really good management of the sessions. It was amazing. So thank you very much. And all of the speakers, now from the older speakers, Dr. Shamshiri is with us. I want to thank him for his really valuable contribution. I myself learned a lot. I'm sure that all the participants also have learned many things. And our other speakers, they are not here, but they were with us and they helped us, and their constructive contribution to this course was amazing. And also my dear colleagues in International Relations Office, during these 6 weeks, they supported us. They provide a very good support for us. Ms. Sadeghi, Ms. Alaeddini, and the other ones. I just want to say thank you to all of them. And at last, I want to thank all the participants. Again, asking if they could kindly fill in the evaluation form and stay with us in the group. We try to maintain this network that we have. And now it's time for the last photo. If you just start your cameras, all of the participants that they want and they can yes, turn on the videos, then we can have a photo.
The last memory of this workshop.
Yes.
I hope we could have another one in near future with the advanced form of evidence-based dentistry.
I hope so.
Yeah.
Okay, so We have some new cameras and videos on now. I can come closer because my face is dark. Okay. Because that light is behind of me, so that's the problem. Okay, thank you. I think those who wanted and those who could, they have turned on their cameras. So
Was it finished?
Yes, I took a lot of,
I could not smile anymore.
yeah, I took a lot of photos.
Thank you very much.
Thank you. Always saying hello is easy, as encouraging, but saying goodbye is difficult. I don't like to say goodbye to all those guys and all those friends I found here in this workshop. It's the truth that I tell to you. And please don't leave us. Keep your contact with us with the link address that was entered in the chat box. Please do not disconnect with us. Dental School of Tehran University of Medical Science is one of the very famous dental faculty around the world with very improved knowledge, and all of the information that is released to students during their education is according to evidence-based approach. I really encourage you, even for a trip after COVID ending for COVID-19 in near future, please, I invite you to come to Tehran and see the dental faculty, at least to have a look as a trip, to see how it is, how the approach of this teaching, how the approach of education of a student, and then you will be encouraged to participate in one of our programs. Please don't leave us. We found new friends, and I like to keep our friendship for always. Thank you and bye-bye. Happy New Year again. Bye.